Botswana COVID-19 webinar session number 8, titled The Emergency Response Coordination Mechanism at District Level in the Context of COVID-19. My name is Untitled Chapter and I work for the Ministry of Health and Wellness, and I'll be your moderator for today's session. And this webinar is co-organized by Ministry of Health, University of Botswana, and Rutgers University. So before I introduce the main presenter for today, let me take you through the webinar housekeeping rules. So if you want to join the mailing list so you can receive future invites, please, you can do so by emailing robert@rmumakwa@yahoo.com. Please mute your microphones, and you can ask questions using the chat function, and we'll monitor your questions, and the answers will be provided during the course of the presentation or at the end during the questions and answer sessions. And there are some questions that were sent before the webinar session, and they've been forwarded to the presenter, and he will address them towards the end of the presentation. The session will be recorded and made available after the session, and our previous sessions, both the recordings and the slides, they are available on YouTube. You can just search Botswana-Rutgers Partnership for Health, and you'll be able to access and view the previous sessions. At the end of the session, we will send you a post-webinar survey, and please, we value your feedback. We ask you to take your time and respond to the survey. So today's presenter is Dr. Allen. Dr. Allen is the Technical Officer for Risk Management and Preparedness, based at the WHO Regional Office for Africa, supporting East and Southern African countries in emergency preparedness and response. He has over 10 years experience in handling humanitarian and health emergencies. And I must say, I attended some of his presentations before at the Ministry of Health, and I can assure you he's very knowledgeable in this field. You are going to learn a lot. And he's been in Botswana for a while now, so feel free to ask him as many questions as you want. Because okay, sorry for non-Botswana speakers here. What I wanted to say is, he's been here for a long time, and he interacted with the ministry for a very long time. And I think now he knows whether we are on the right track or not on the right track. So feel free to ask him. That's how we are going to learn from him. Dr. Allen, the floor is yours.
Thank you, moderator. And thank you for letting me make my presentation. I will take you through some key principles of management of public health emergencies at the subnational level. And today's outline will be basically, I will go through the Can you hear me? Yes. And then we shall talk briefly on the role of critical functions. And then I will end it up by briefly talking about and discussing the role of rapid response teams, which is the critical arm of the emergency response when it comes to public health emergencies and outbreaks. Next. So the general objective of this presentation basically is to provide an overview and guidance to the district teams in setting up an effective management and coordination mechanism for health emergencies at subnational level. Specifically, we shall look at the role of the district task force. We shall briefly talk about the core responsibilities. Once again, we shall talk about the emergency management structure, the role of each critical functions, and also want to ensure that the districts, by the end of this, the district staff in their respective capacities should be able to work as a member of the emergency medical structure to handle emergencies effectively. Next. Just to give you a historical perspective of some issues in management of emergency response, I mean, there are some challenges that usually come up. The lack of leadership, majorly related to qualifications or judgment, as you may be aware, you need to be very decisive when it comes to emergency response. Issues of coordination, lack of coordination due to failures in cooperation amongst the relevant stakeholders. Lack of integration due to a lot of competition among stakeholders, wanting to outshine each other. Lack or loss of resources, and this is majorly due to lack of planning for emergencies. Lack of planning itself due to absence of commitment from the relevant stakeholders, and lack of media support, majorly due to all of above, but also failures in risk and crisis communication. Next. There's what they usually call a gray area in emergencies, when you have new players with unfamiliar roles, issues of heavy information demands, politically sensitive issues, for example, like the current COVID worldwide is quite sensitive, changing requirements as you continue moving in the cycle of the response, decision-making, degraded communications, and unforeseen consequences. So these basically are slides that just to set the scene. But good coordination aims aims for a needs-based rather than capacity-driven response in order to improve capacity, predictability, and accountability. Those are very, very critical. And good coordination is built on existing Ministry of Health structure. Once you try and do coordination out of the existing Ministry of Health structures, then you're losing the game. Next. And it has been shown that health responses that combine both national and subnational coordination have been found to be more effective than those who are coordinating each other, who are coordinated through a single national cluster. As you may be aware, the subnational level, which is the district, for example, for the case of Botswana, is one of the main critical piece to ensure effective response. And through subnational coordination structures, though the subnational coordination structures may vary across regions, it usually facilitates decentralization in terms of decision-making, and this, in time, shortens the response times. It's very critical to shorten what they call a response time in emergencies. So, strengthening subnational coordination at district level helps to, one, strengthen accountability to the affected people. Whatever we do, actually, we are doing it for the affected population. Adapt the responses, including priorities to the local circumstances and context, is very, very important. So you have to involve the community and ensure that you adapt whatever response based on the context. Work closely with the local health authorities and partners. Support real-time implementation of the national COVID national response plan. And of course, not forget addressing cross-cutting and multidimensional issues arising from the context that you're working in. Next. So what is effective health coordination? Basically, it's getting stakeholders together to understand what the problem is, what are we doing about it, how are we going to go around it, what resources we need, and how effectively shall we monitor the progress. It's very, very important to monitor the progress of your response. Next. But why do we do coordination? It's major to provide a common framework for district approach to emergencies. We have visited a few districts and we noticed that they have a different approach. It's high time that based on their context, they have the common principles should be within the common framework. Strengthen multi-sectoral team approach, joint planning and implementation, clarifying roles and responsibilities of each actor, and ensure that you have one coordination structure and mechanism to avoid duplication. Once you start duplicating efforts, then it becomes a challenge to have what they call a focused response. So we shall go to the role of the district task force For the case of Botswana, you may want to call it the District Health Management Committee, but I'm told the nomenclature is changing. But it's still a task force. We have 3 levels. One is the strategic level, one is operational level, and one is the tactical level. Just press. The strategic level basically is for, basically as it is, strategic guidance and decision making. It does not, it should not venture into operations and any decisions at the tactical level. And in most settings, it should be the district task force or steering committee or the district disaster management authority. It's quite high level. It's supposed to leverage resources and capacities from other sectors. Then the other level now is the operational level. This is where you coordinate the response elements and ensure that you're on top of the game, what they call situational awareness. It changes all the time. And that's where now the planning aspect becomes very, very critical. Again here, it's majorly done at the EOC level, the Public Health Emergency Operations Center. The strategic level may be possibly, in some settings, you may consider what they call the National Emergency Operations Center, that's multi-sectoral. But Ministry of Health Emergency Operations Center should coordinate all the operational responses. And then tactical is basically a field level. For example, if you're at the district level, your strategic level could be at your district level where you have your commissioners, where you have your various sectors, health, you have water, environment. Operational may be at the district level where you possibly have an operational hub, and various sectors. And then tactical is at the community level where you have basically where you're taking decisions on the ground. And that's where you pick most of the information that guides other decisions in the other 2 levels. Next. So the tactical level is the site of where the emergency is. If there's a case, or if there's case management, if there's a confirmed case in area X and you have a case management facility there, that's a tactical level. If you have a cholera outbreak and you're doing oral vaccination for cholera in the community, that's a tactical level. Operational level, as I told you, is where the critical resources are monitored and dispatched. We shall talk about the EOC briefly. So when we talk of resources, we shall bring in the aspect of EOC. And it's important that you can have more than one tactical area. So it's important that at the operational level, you are aware of that. And if critical resources become scarce, the people who are supposed to be dealing with the situational analysis and awareness can guide the operational and strategic level where to channel these resources. And I told you strategic coordination and policy making is basically at a large level, and it's usually for large emergencies. Next. So what are the core responsibilities for the district members, the District Health Emergency Task Force? One is to establish a clear management structure for the response at the district. This is very, very important. We shall talk about the state management system shortly. Very important to have a clear management structure, someone held accountable for the response, someone who should take a decision and deploy resources, but also guide the response. Undertake timely, independent risk assessments and situational needs analysis and assessments. Over time, as you respond to outbreaks, you should periodically conduct risk assessments and needs assessment to know how the outbreak is evolving. You should be able to categorize your areas of operation in terms of the level of risk. You need to know what capacities for case management are in area X, how many health workers are there, how many have been trained, what is the referral system there, How ready are the health workers? What's the infection control rates? What's what's the case fatality rate? So it's a composite kind of assessment that you come up with some kind of risk levels. The district also has a role to deploy sufficient expert staff and materials early in the event. Ensure that the existing disease surveillance system is adaptable or is adapted. Early warning and contact tracing systems are in place to continuously monitor the response. Capacity building, I'm aware in Botswana they have done a lot of capacity building efforts. But again, training health workers is one thing, but ensuring that health workers are actually implementing what they have been trained on is another. Undertake resource mobilization efforts to support the response. This is guided by your needs and by your response plan. Now we have crossed the preparedness phase, so we're in response. Mobilize stakeholders and ensure proper coordination response. You have to map out your stakeholders and understand what they can bring on table, what comparative advantage they have in the response. And all this should be mapped against the resources that are needed to effectively deliver on the response. And of course, monitor and evaluate your response. Next. I just wanted to show you the critical functions and sub-functions. Ideally, whenever you're responding to any health emergency, especially outbreaks, you need an incident management system. The incident manager usually takes the leadership. Note that the incident manager does not necessarily have to be a technical person in that area, but has to be able to move the response. There are some key functions. Majorly there are 4, but in most cases we add the 5th one, which is partner coordination or sector coordination of some responses. So, and if I'm going to quickly go through the 4th, finance and administration. This one looks at finance, budget, grants, management, procurement, human resources. Operations, support and logistics. It looks at supply chain management, field support, and what they call health logistics. Like now where teams are in the field and they're trying to assess isolation facilities. If they recommend that districts need to establish what they call isolation facilities, then people who have expertise in health logistics, setting up, the isolation facilities, putting into consideration the IPC, the patient flows, the cohorting of patients. So have to be under operations and support logistics. Health operations and technical expertise, usually one of the largest. Looks at prevention and control measures, looks at risk communication, which is very, very critical in outbreak response. Health service delivery, technical expertise and research, training and health staff. Information and planning, very important. Usually managed by epidemiologists and people who are into strategic planning. You have to do risk assessments, establish your surveillance and early warning systems. You have to periodically monitor the surveillance, the trends. Like now we're in a phase whereby all districts should be able to monitor the trends of acute respiratory tract infections, the trends of influenza-like illnesses, the trends of COVID-like illnesses. We're into winter. We should be able to monitor and know which area is reporting high numbers. If you see an unusual number or a trend, then the rapid response team goes in and verifies, and either discards the alert or takes it up and institutes a response. Partner coordination, we are talking of intersectoral coordination, and of course liaison with either the communities. Some communities are very difficult, to infiltrate, and it's a little bit of a challenge. So you need to ensure that you have strong partner coordination. Of course, staff health and well-being and security, communications, external relations, and EOC management. Next. This is just basically a summary of the district health management system. As I told you, management, responsible for the overall operation of events, including coordination and risk communication. Operations at the field level provides direct support to the response. of the event. And then at a higher level, provides coordination and technical guidance. So you have to be very clear on what guidance, what actions you're taking at higher level and also at the field level. Planning, data collection, analysis, planning for the future, looking at trends, the modeling of how the outbreak may progress, and you tag this to the resources that are available. Logistics acquires, tracks, stores, maintains anything to do with supplies, transport, what they call support functions or core functions for the response. And of course, finance, looking at cash flow, per diems, budget implementation, grant management, and any other administrative records. Next. So looking at the functions, these are the critical functions of the emergency management system, which are usually led by the districts, but you can mirror this at the national level. As I told you, leadership, health leadership, and ensure that you are in charge of the event. Multi-sectoral partner coordination, information and planning, very, very strong pillar. Health operations and technical expertise, operations, support and logistics, finance, and human resource, and surge management, very, very important. I want to talk briefly about the incident management system. I think there's a problem with the slide. Can we? Next. Yes. No, previous one, sorry. Yeah, the incident management system. The incident manager basically usually uses the infrastructure of the EOC to do their role. And he supervises all the functional leads, the other 5 pillars that we talked of, to ensure that the critical functions under each pillar is delivered. He delegates most of the responsibilities and retains responsibility of any function that he has not delegated. For an effective incident manager, you should not indulge in whatever responsibility that you have delegated. If you have delegated the responsibility of planning and strategic planning to person X, you basically have to follow. You just provide an oversight, but you do not indulge in the nitty-gritties. We are trying to avoid someone who is at the strategic level to directly communicate with someone who is at the tactical level. So in this incident management system, there's what they call a span of control. You have to ensure that you can only supervise 5 people. If you're supervising, if you are in a position of leadership and you realize that you're, especially for health responses, and you're supervising more than 5 people, then it's more likely that you're not going to perform effectively. Next. The management function is executive, strategic, and operational commands. It assumes the overall responsibility of the response and provides direction based on authority that has been provided to, by the institution. For this case, it's Ministry of Health. If they appoint an incident manager, they have to delegate the authority and give him explicit authority to do most of the actions in line with the objectives and strategies of the plan that they're implementing. Decision making is very key and critical, and you have to be decisive. And those are some of the management functions as part of the incident manager. Next. The planning function, very important. You need a very strong epidemiologist or a strong public health specialist to handle this. Ideally, he guides the response. So say at the district, if you have a very strong district surveillance officer, he takes charge of this. He's supposed to collect, process, and analyze data on a regular basis. He's supposed to identify strategies and objectives to address the emergency. He's supposed to give situational reports. He's supposed to prepare and distribute plans, and then once in a while, conduct evaluation exercises and response. We are in a situation whereby by now we should be having a midterm evaluation of how we have been doing so that we can re-strategize and redesign our response. Logistics is almost clear. It's an activity that deals with ordering, distribution, maintenance, and replacement of materials. Of course, not forgetting infrastructure and providing services to the response, and staff welfare. Finance and administration, very critical as part of the incident management system. It tracks expenditure, resources, makes payments, provides administrative services, and of course, it partners with the logistics function to ensure that no funding is not spent and all the funding is available to support the response needs. So as you can see, all the functions under the incident management are very, very important. Next. People may want to ask the difference between, the role of emergency operations center in this response or in the response to emergencies. An EOC is basically a physical location. So like in this room can be an EOC. You don't have to have a full, a flash room. You can even have an EOC under a tent. And it's an essential element and platform of the emergency management system. And it coordinates, it has about 4 functions. 1, it coordinates information and resources. It ensures the situation analysis awareness. It makes operational decisions and supports implementation of plans and procedures. Actually, if you combine those two, basically it's mobilizing and deployment of resources, and also collecting and harnessing whatever information you need to guide your response. So ideally, the incident management system is supposed to be implemented within the confines of the EOC. If you do a crosswalk between the incident management system and the EOC functions, you will notice that the functions usually provide support to a similar output. Next. Yeah, those are the 4 elements of an EOC. If you understand those 4 elements, then you understand what it needs. As I told you, an EOC basically is a location for coordinating responses. Studies have shown that those where EOCs are, you tend to have more focused response. Physical location, which is look at infrastructure, the computers, the EOC manager, basically as in a location. The body of data and information management, that's where you have where the surveillance team, works within, and you're looking at computers, you're looking at screens, you're looking at information management specialists, you're looking at capabilities for infographics, you're looking at strategic guidance. Then a variety of plans and procedures, all plans that are developed during a response should be kept at the EOC. The EOC should access, and actually the EOC should also be accessible by anyone who is participating in the response. If I want a plan for training, if I want to add procedures, if I want to know what SOPs, if I want to know what guidelines, you go to the EOC. And lastly is a roster of skilled trained personnel. Just to let you know that the performance of an EOC is equally as good as the people that you have there. So it's not about having an EOC and performing. So the roster of skilled trained personnel, the roster of all these people who have been trained. For example, we have done a lot of trainings now in Botswana. We should be having, the EOC should be having a roster of all those who are trained and where they're deployed. All surge capacity plans. If you want to surge a particular district, who do you rotate? Who do you pick from facility X to facility Y? A roster of all people who are trained in incident management system, a roster of all public health specialists. So those are the 4 elements of an EOC. And this can be done both at national level, but also most importantly at subnational level. Next. An EOC must be supported by legislation. Issues of sustainability have to come in mind, appropriate plans and procedures, but most importantly, a well-trained and well-exercised staff to run it. So I want to, I'm coming towards the end of the presentation, but I thought I would talk about the public health emergency response. I visited a few districts and I noticed if we talk about coordination, they usually talk about the public health emergency rapid response team. These two are different. This is usually a technical arm of the district health management team. Just like how you can have a Ministry of Health and then maybe have a public health institute, just as a technical arm. And before you investigate, not necessarily for COVID outbreak, you need to mobilize what they call a public health emergency rapid response team. This is basically a pool of experts at that level that should be able to perform some key roles. And before they go in for any investigation, you should prepare the team with appropriate information and data about a suspected COVID. The team members should be refreshed about the signs and symptoms. You should mobilize the public health rapid response teams and make arrangements for investigating within 24 hours. This is an indicator. I usually ask the districts about what they call an alert log. Whenever you have an alert, in how many hours have you responded to? I mean, how long has it taken you to respond to this alert at the district level? You need to have a multidisciplinary composition of this team to support the field response and ensure that the overall district coordinator and other relevant staff have been identified prior to the event. So this is part of preparedness. So rapid response team majorly is to verify alerts, but it's a pool of experts that is identified prior to an event. Next. And basically these are the functions: coordination, epidemiology and surveillance, laboratory, case management, IPC, environmental health and sanitation. And these are adaptive, are flexible. Assuming you are dealing with zoonotics, instead of having possibly someone for just an example, for let me say mental health, you may have someone from vet department. If you are dealing with a public health emergency for like a radiological spill, you have someone from radiology department. So those are the key functions, and those functions ideally go with the technical expertise. Next. Just to remind you that before you coordinate any field response, you have to specify the tasks for the rapid response team, define supervision and communication lines. It's very important for a rapid response team to have one leader when you reach the field, especially community level. Not everyone talks, not everyone talks to the community, not everyone decides what to do. Obtain required authorizations from the tactical area. If I'm going to Maun, I need to get clearance from the DHMT there. If you're in Maun and you're going to District X, you need to get clearance from either the in charge of the hospital or in charge of that district. You need to arrange transport, gather supplies, ensure adequate personnel, PPE is available, and adhere to IPC. This is very, very important for pathogens that are highly infectious. This is, I think, the second last slide, just to flash the role and responsibility of the RRTs to investigate rumors, alerts, and reported public health emergencies, coordinate rapid intervention response actions with partners and agencies. It's very important that you implement proposed control measures once you go to the ground. You don't go and just collect specimen and collect a patient, and you don't implement response measures. Next, propose strategies and control measures. Prepare a detailed investigation report. For example, COVID was declared in Botswana here, so we expect a detailed investigation report. And in the event that usually in the beginning of the outbreak, you have one detailed investigation report, but now that you have sporadic cases, each case has what they call a case report. So since now, if we are 39 cases, each case should have what they call a detailed case report, or about 1 page, because these are some of the aspects we look at when we're doing what they call after action reviews. And then finally contribute to final evaluation of the outbreak response. Finally, when the outbreak is declared over, we expect the government also to declare the outbreak over. And then within 3 months, the Ministry of Health sanctioned what they call an after action review to come and look at what has gone well, what did not go well, and what can be done better. So basically, this is the principles. These are the principles of health response at the district level, and if they are followed, if they are followed critically, then throughout the cycles of the response, it should be an easy area that the DHMT should be able to implement when it comes to other outbreaks, not necessarily COVID. And COVID should provide a platform for doing things better, when we're faced with outbreaks in the near future. So thank you very much. I've been a little bit fast because of time, but I'm open to questions, and I'll be able to take some, and those that I cannot, I'll possibly answer them at a later time. Thank you very much.
Thank you.
Yes. Okay. Thank you very much. Yeah, no, the managers are not quite many. Usually in an outbreak response or a health emergency, you just have one manager who is the incident manager. However, you have other pillars. Actually, I didn't talk about the other. I mean the pillars of overall coordination. But we have those pillars of management, of planning, and surveillance and planning. You have one of logistics. Then you have one of partner coordination. And all those report to one manager. Now, under health expertise and operations, you have a sub-manager, not a sub-manager, sorry, you have a technical, you have an officer who is in charge of what they call continuity of services or service delivery. So that is a person who is supposed to coordinate service delivery in terms of, in the context of COVID. For example, now we are talking of continuity of services. Actually, in Botswana here, it was annexed to the pillar of case management and IPC. Yes, so that's where we put health service delivery. But remember also, the overall response to the outbreak or to the health emergency is also part of service delivery. It's actually part of the service delivery. It's one of the critical functions of coordination to ensure that you have adequate service delivery. Then one was asking about audits. Yes. There are a number of assessments that have been done. As we speak now, also there are teams that are moving to all the 18 districts, and they are doing assessments. They are doing health facility assessments. They are looking at the overall operational readiness of the district. Even before that, they had the Ministry to mount initial response. So yes, a number of assessments have been done, and I'm also aware that I'm told that the Short Task Force has also done its own risk assessment. So there are assessments that have been done, but also we are trying to encourage the surveillance team. That's why I told you the planning pillar and the surveillance team are supposed to periodically do assessments and look at the data of surveillance, because that's one way where we can know where we're heading. Yes.
So the other question is, are the queues outside shops another source of people crowding? Doesn't that defeat the purpose of social distancing and infection control? Because they feel like long queues. And then the other question is, are all hospitals equipped with materials for COVID-19 testing?
Okay. Well, about the queues, I think there was clear guidance about social distancing and how to manage those queues. Ideally, it's, first of all, safety begins with an individual. It's your responsibility as an individual to protect yourself. Ensure that you have a mask. Ensure that if there's a crowd, I mean, first of all, you have to go to the stores only if you have to, but also it's important to observe social distancing. You know, stay 2 meters apart, 2 to 4, from the person before you and after you, because it's true, if you don't maintain social distancing, it can be a potential source of infection, especially if we have someone who possibly could be incubating or could be asymptomatic. So please follow what the guidance that is out: social distancing, wear masks, and sanitize your hands, or use soap and water. And most of the stores, I think, are offering that. Yes. So then, all hospitals, not all hospitals could be having the capacity, because this is an outbreak. I mean, the Ministry of Health has identified specific centers to do testing, and I think they have even expanded the capacity to test to some districts. Yes. However, all hospitals are able to screen and triage. Should be able to screen and triage and refer appropriately. If you think someone has met the case definition, the criteria of the case definition for a suspected COVID, then you refer to the isolation facility. If you assess and you think the patient is not a suspected case of COVID, then you refer them for routine care. Yes.
Okay, the other question is, how is the linkage between private clinics and emergency response team? And how will regular communication about COVID-19 occur between or among HMTs?
The linkage between private clinics and RRT, that's one of the areas that the DHMTs are supposed to strengthen. And actually the Ministry of Health is trying to strengthen that, to ensure that all the surveillance team, I mean all the surveillance data from the private clinics, are accessed by the Ministry of Health. I know there are mechanisms that are in place to ensure that the people from the private sector are reporting. This morning I was in Ramaswa for a DHMT meeting engagement, and they have gone ahead. They even have a WhatsApp team, a WhatsApp group that has both the public and private providers, which is good. They share information and they attend. Actually, we had part of the meeting, we had people who were from the private sector. So I think there's good work in progress. But this is an area that needs to really be strengthened, because we have seen data in some countries, the private sector actually has really been hit. In some countries, a lot of health workers, especially where the private sector, have been affected by COVID. Regular communication is a responsibility of the DHMT. They have their pillar heads in charge of communication and risk communication, and it's imperative that they communicate. I mean, even between zones. I mean, if you're in Greater Gaborone DHMT, you should be able to communicate with your counterpart in Southeast or in Northeast, so to speak. So that's one area that the DHMT lead should ensure and put in place.
Okay. The other question is, What are we doing about business entities that have their workers wear face shields instead of masks? And what are we doing about thermometers that record very low temperatures? How are we validating them? And what do we think of BOMRA saying that a normal temperature is between 36.1 and 37.2?
Some of these questions are very difficult. I will try and I think the business entities, I'll have to take back this to Minister of Health if it remains a concern. But there's clear guidance. Business entities were given clear guidance by the Minister of Health on what to put in place when they're opening, and they should follow up. And I'm sure the MOH will take it up and do monitoring. So I agree that face shield alone, will not protect the other person. I mean, let the business entities follow the guidance from Ministry of Health regarding infection prevention and control, and that's among them is use of face mask. Thermometers, yes, it's a challenge. All thermometers should be calibrated. This we have discussed with colleagues in the Ministry of Health. I agree with some thermometers do. The particular shop that I enter, whenever I enter there, the thermometer never takes my temperature. I don't know why. So it's a challenge, but other people, you find it taking temperature. So, but yes, thermometer. I mean temperatures. Sometimes recorded low temperatures, which is a concern. So as you said, the thermometers have to be calibrated, and I think we have biomedical engineers in the Ministry of Health. There's a unit that's supposed to be handling this and is handling this. So, and whenever we visit these stores, we tell them, please go and have your thermometers calibrated. It's not a matter of just picking a thermometer from the pharmacy or from the store and using it. It has to be calibrated. There was a third question about?
The other one was...
I think one was a business entity, one was recording thermometers.
Thermometers, and then they're saying BOMRA is saying the normal temperature is between 36.1 to 37.2 for these infrared thermometers.
BOMRA is, if it's an agency from the government that has decided that, then I mean we go by the standards that are accepted. Each country usually comes up with the standards. So it's up to the Ministry of Health to come out clearly on that. Yes.
Maybe this formulation you could take it to the minister.
I think maybe the question is that
the ministry. The 36.1 is the 37.2.
Yeah, the question maybe is that if it's 35, which happens sometimes, what needs to be done? Maybe that's the question.
Well, basically, when you look at the thermometers and the package inserts from the manufacturer's description, they range from 32 to 43 degrees Celsius. That becomes a challenge because some of the centers take your temperature outside. Mm-hmm. Let's say the temperature is less than 32 degrees. Mm-hmm. That's why every time you go to these supermarkets early in the morning, the thermometers do not record because they are calibrated for that range, 32 to 43 degrees Celsius.
Okay, thank you. Yeah. That explains a lot.
Okay, the other question is, can we empower healthcare workers to be able to report people or entities that are violating COVID-19 protocols? And would there be antibody tests soon so non-acute infections can be monitored? And what is the role of WHO and SADC in managing movement of people across borders and how they are quarantined?
Let's repeat the second one.
The second one. Will there be antibody tests soon so non-acute infections can be monitored?
It's about health workers being empowered, not only health workers, but anyone who is not compliant with the guidance of the Ministry of Health. I mean, because it's everyone's role and responsibility to ensure that this outbreak is contained. So if the Ministry of Health has given you guidance really, and you're not following it, I mean, you're not being compliant, it's unfair on your part, but also unfair to the citizens of Botswana. So I'm sure there must be mechanisms to bring to book anyone who is going against those protocols. But also the business entities and the institutions have the right. I mean, like where I work, I cannot enter if I don't have a mask. If I don't sanitize, they will not allow me in. So I mean, it's a collective effect, and I'm sure this not only for the health workers, but for the community. Regarding movement across the borders, we are trying to establish cross-border mechanisms. Actually, the Ministry of Health has established communication, is in communication with the neighboring countries, and there's cross-border mechanism. And even IHR, they're in touch with the fellow IHR across the country. I know in Zimbabwe they've been talking. So they are managing this cross-border movement of people and trying to see that they contain this outbreak. About antibody tests, of course, a lot of research is ongoing, and different countries adapt to different mechanisms. For now, I think Botswana is basically, I mean, it goes by the confirmatory test, which is the gold standard. However, a lot of studies and publications are coming up, and WHO is also looking at the various studies and trying to support validation of some of these tests. So when they are available, yes, they will be availed, and they should be able to guide the response. Did I miss out any? Health workers, movement of borders, and then antibody tests. There was role of WHO and SADC. It was the same thing as cross-border. Yeah. Yeah, SADC is a regional economic body. WHO remains a technical agency to the member states. So we work through the actually this morning there was supposed to be a meeting, a webinar meeting between SADC and some partners and WHO and the Ministry of Health of the East and Southern African countries, basically to discuss cross-border engagement and information management in the context of COVID. So there's a lot of work. There's a lot of work. SADC is engaging in the governments. I know they have come up with guidance on managing of trucks and movement. So we continue to provide the relevant guidance, but also it's the responsibility of the various governments also to ensure that they play a key role when it comes to managing cross-border movements and of course trade. But however, WHO IHR maintains all public health measures should not interrupt trade and international movement, and I think the countries are working around this. Over.
I think Dr. Charles Neal, I think your hand has been up. You can go ahead and ask your question. Charles.
I think you answered all the questions. The last question that I had asked was on cost effectiveness. I don't know if this is the right platform. We currently quarantine all our clients who come through the border for 14 days. We offer them, unless they're currently anyway, the protocols state that unless they're a truck driver, they get the test done at day 10. There has been a couple of other people who are not truck drivers who have gotten the molecular testing or PCR done at day 1, which is when they enter through the border or airport. So now the question was, since we spend a lot of money on quarantining facilities, would it be more cost effective to actually offer PCR testing at day 1 and at day 10? Day 1, so that in case there's a positive client coming in from outside of the country, they go straight to SKMTH rather than going into quarantining and waiting for day 10 to have their test results or the test done. And then the last one was just a comment. It was just to thank Dr. Allen for the beautiful presentation, to thank him for giving his time and opportunity to give us this great presentation. And I personally, being a public health resident, have learned a lot. I hope I'll learn more as I hit the ground running. Thank you, sir.
Thank you for the compliment. I appreciate. About cost effectiveness, yeah, I know a lot of discussions have been around that, but the guidance currently, the guidelines for quarantine and management of travelers across the border in Botswana is that they are quarantined for 14 days and then tested up to 10 days. For as long as that still remains the guidelines, then it will be very, very difficult to change. Now, and yeah, I know of course there's some costs attached to quarantining, but we also need to understand, I mean, it's better you contain potential spread of the disease by having whoever someone who is potentially exposed quarantined than allowing them in the community, and then we get a full blown outbreak. About the periodicity of the testing, I think the case management group and possibly the surveillance group will have to discuss that. But as it is now, we're implementing the guideline, and for as long as the guideline is not yet amended, it would be very difficult to have, to adjust on the protocol of testing. So, but I understand your concern, but as it is now, we are following guidelines, and I'm sure there are discussions regarding reviewing some of these things, so we shall be informing you. About the costs, I may not comment on that, but yes, I hear you.
Okay, there's one question that I've omitted that was sent. In the light of the Zimbabwean deportees alleging that they contracted COVID-19 from Botswana when they were repatriated back to Zimbabwe from Botswana, would it not be better to test every deportees in future to be certain of their status, to making contact tracing easy? Deportees can even contract the virus in quarantine centers back home if they are tested many days after arrival.
They're absolutely right that there's a possibility that they can pick the infection in the quarantine site. I don't know how long it takes from here to Zimbabwe. There's a possibility they can also pick it across, I mean, as they move the bus. Some countries are doing, as part of the public health, as part of adjusting public health social measures, some countries are doing exit screening and entry, and in addition to entry screening, meaning that if you want to fly out, say to South Africa, and they test you and you're positive, then they retain you. Yes. So I mean, it depends on scenarios. It may be difficult. We do not know whether you call them deportees, but we don't know whether some of them, jumped the border going that side and they were put in quarantine. But yeah, it's a challenge. We may not know where they picked the infection, but I know the contact tracing team has been, through the IHR, have been in touch with Zimbabwe. They have identified the locations where these people have been working, and I know that they have moved there to try and elicit information on possible contacts. So response is going on, and you're right. There could be a possibility that that if the country has resources, could possibly do exit screening for the deportees. But also, if they have good arrangement with the country that is receiving them, the country there should be able to test them once they receive them from Botswana. So it's all about, and all those come in when you establish a good cross-border mechanism and areas of collaboration between the countries. Just like how some countries are managing trackers. You have to test as you leave a country before you cross to another country, and then also when you arrive that country, because of the time lag, I mean the time difference between your departure and your arrival, they test you before they let you in the country. So all those are the modalities that the coordination teams can work on. Over.
Okay, I think we are running out of time. Let me just take one more question. Anyone with a burning question? Just one.
Yeah, can I just follow up on that, please? It's Sunanda Ray speaking. May I go ahead?
Yes.
Okay, so just following up on this issue about the cross-border people, because obviously I have an interest in what's happening in Zimbabwe as well. And I think the issue is that if you identify people who are returnees from Botswana and you do contact tracing, but these are people who've come from communities in Botswana where they're living in overcrowded conditions, they may be working illegally. Are you likely, if they don't feel confident that the authorities will respect their desperation in a way, will they give you the right information? We know that people give false addresses, etc. So how can we, in the interest of public health, this is always a difficult one, that you want people to give you the right information. We faced it with TB as well. You want the right information so that you can do the contact tracing. But when people feel that you're going to then go and investigate houses which may have 10 people sleeping in a room, then that's a very dangerous situation where the balance between human rights and trying to resolve the public health problems. So that's why I'm interested in how WHO can actually protect people so that they're willing to give their details. Thank you.
You're very right that it's more likely that even the deportees or the border jumpers that have been quarantined in Zimbabwe are possibly giving us wrong information about where they have been working, because some are saying they have been working at construction sites in place A, place B, So, but as it is now, it's purely, we have to depend on the information that we get from the member states. However, if there is a clear cross-border mechanism that has been established with clear MOUs between the two countries or between the two member states. For example, if it's true that they are deportees, then the country deporting the people should have records of who they are deporting. So the other country receiving them should be able to provide feedback to the country that has deported these people that so and so have been tested positive. Please go ahead and initiate contact tracing around the area where they were staying. But I totally agree with you that that issues of human rights and what. However, in outbreak response, usually there's a lot of confidentiality. We do not disclose names of patients unless it's really for public health use. But as you notice, the community does not know who is sick and who is admitted, who is quarantined. And however, we can get whatever information we need from the people who are managing the cases, or from the member state that has received the deportees and returnees, to be able to initiate some kind of contact tracing or possibly active case search in the areas where where they existed. So it's a challenge, but just to let you know that WHO works through the Ministry of Health, and usually some of those issues regarding confidentiality and human rights, usually it's the government that takes them up. For us, our role majorly is provide the technical guidance and advice when it comes to public health actions. But I hear you, and your concerns are really valid. Over.
Okay, I think we run out of time, so I'm going to close the session. So let me thank you, Dr. Allen, for the wonderful presentation and for your time. We know that right now you should be in the field, but you find it fit to come and join us. And you, the audience, thank you so much. Ghana, there won't be any webinar without the audience. So we thank you as well. So please don't forget to fill out the post-webinar survey. The link has been provided in the chat box. So we do value your feedback. And also comment about the timing of the webinars, because that's also important since now we are no longer in lockdown. And thank you for Rutgers University for making this online meeting possible. Bye.